live this video for gynecological sessions. So there are 19 to 20 questions. So the first question is a case of preeclampsia post-cesarean section. Patient is type 1 diabetes and her blood sugar is 280 mg per deciliter and patient was drowsy. Respiratory rate is 10 per minute. Urine output is oliguria and patellar reflex is bilaterally absent. What is the cause of drowsiness? The option are MGSO4 toxicity, diabetic ketoacidosis, postpartum eclampsia. And so in postpartum eclampsia there might be the high blood pressure. And in diabetic ketoacidosis the blood sugar should be greater than 500 or 480. So the answer here will be MGSO4 toxicity. MGSO4 there is patellar reflex is bilaterally absent and respiratory rate also decreased. Urine output shows oliguria. Okay. So moving to the next question. Patient with normal BP, normal coagulation profile at least 75 IU, LDH 400, PLT 75,000. What is the diagnosis? So the cholestasis, HELLP syndrome, AFP, and acute hepatitis. For this we have to show this table. The hyperemesis and the onset of pregnancy is early. Clinical finding severe NNP, AST is 300, bilirubin, NL4, creatinine increase, HCT increase, platelet nil, PIM nil, PD nil, PT nil, and hemolysis no. When cholestasis is late, the pruritus NL, AST NL 200, bilirubin 1 to 5, creatinine nil, HCT nil, platelet nil, fibrosin nil, TD nil, PT nil. Okay. Then fatty liver, the late onset, the moderate NNV with hypertension, liver failure, 200 to 800, 4 to 10 bilirubin, and creatinine increase, HCT increase, platelet decrease, F5B decrease, BD increase, PT increase, hemolysis increase. So in preeclampsia, mild to moderate, HA and HDN, NL 300, 1 to 4 is bilirubin, creatinine increase, HCT increase, platelet decrease, then DD, F5B nil, DD increase, and NL, and lastly the hemolysis will increase. In hepatitis, the variable jaundice 2000 plus is the value of the AST and bilirubin is 5 to 20. Then creatinine is increase and there might be HCT and HCT increase, PT decrease, PD NL, then 5B is nil and PT is increase. Okay. So by this chart we can answer the HELLP syndrome. Okay. Moving forward to the next question. So primary normal regular cycles now delayed for 2 weeks with vaginal bleeding, abdominal pain, beta HCG is 1400, UPT negative, BP normal, adnexa normal, USC triluminal appearance, next step in the menu. So the serial beta HCG every 48 hours, 63%, so it will be intrauterine pregnancy, as above 50% but less than 60%, 63, so it might be ectopic. Fall in beta HCG or rise in less than of failed IVP. Okay, so here the PT is positive, UPT was positive in this question. So in this ectopic pregnancy case we should do repeat the beta HCG after 48 hours. If it's positive, so we can go for laparoscopy. Okay, so the answer will be HCG after 48 hours. The structure being given traction got torn and led to extensive vaginal bleed. Which of following is the most appropriate step? So here the placenta is removed. So here we are doing the manual removal of placenta. The oxytocin can't be given again. If any such should not be done because it is not postpartum hemorrhage. Another question is what kind of pelvis is this? So if we can see, so here this line is shows kind of greatest pelvic diameter is the, and this blue color line is the mid pelvis. Anatomical outlet and obstetrical outlet is below L5 to pubic symphysis. Is here this line is obstetrical outlet, and below the obstetrical outlet there is anatomical outlet. Okay, this is inlet. This is inlet. So the answer here will be mid pelvis. Mid pelvis is between plane of greatest pelvic dimension and below the mid pelvis plane. Here you can see the greatest dimension, least dimension, distal spine, boxes. At least what level? Next question is at least what level is uterus to be felt on second day post delivery? 1 finger below umbilicus, 2 finger below base, 3 finger and 4 finger. So the 30 cm of the upper pelvic symphysis rate as increase in the fundal height is 1.5 to 2 cm by 2 weeks. It becomes a pelvic organ, and weight for uterus is 1 kg by 4 week and 100 gram by 6 week to 6 gram. So the year the second day post for delivery, so 2 centimeter, so 2 finger below the umbilicus will be the answer. In the embryological development testis should release testosterone. What makes it release the testosterone? So the answer will be HCG from the placenta. It's the main cause for release of testosterone. So next question, multigravier was in the second stage of labor for more than 2 hours. On per vaginal examination, the fetal head is palpable at the level of distal spine in the ROT, right occipital transverse position, and the sagittal suture is palpable in the transverse diameter in the inlet. Molding positive in the Caput positive. What is the further management? So here is the diagnosis is deep transverse arrest, and only the sagittal suture is palpable, and also the 2 months has occurred. If there is 1 month has occurred, so you can try for vacuum, but already 2 months has occurred and there is deep transverse arrest, so we are using here the LSCS will be the answer. Now another question is G2 P1 with L1 with history of previous cesarean section, presently with 35 weeks of gestation. If presentation is the no batch patient want to try for vaginal delivery, what should be your next step? Here is the previous classical cesarean section is there. So in the previous classical cesarean section, we are only doing the elective cesarean. Okay, in the classical cesarean section, if there is a LSCS, so we can go back to the TOVAC. Okay, vaginal delivery after cesarean section, but here is the classical cesarean section, so we can't do the vaginal delivery again. Okay, so the answer here will be. Okay, the next question is secondary wave of trophoblastic invasion. So arteries are arcuate artery gives the radial branch, and the artery gives the basilar branch, and the basilar artery gives the spiral branch. So the arcuate artery will be in the outside of endometrium, and the basilar and spiral artery will be in the endometrium. So here you can see the in villi sensory trophoblast, hypotrophoblast. The spiral arteries is going outwards to the extravillous trophoblast. So the answer here will be So in the cytoblast you can see the spiral arteries only, right? So invasion of the spiral artery by extravillous trophoblast. Elder artery and anterior artery will be in the symmetrium. Another question is what type of hymen is this? Okay, this is perforation is seen, so choroid hymen will not come. These are types: choroid hymen, angular hymen, septate hymen, scribiform hymen, and the varus annulus hymen. So the answer here is septate hymen. Another question is contraception of choice in 18-month in mother breastfeeding patient having irregular and heavy bleeding. So what should be inserted? So if the property is inserted, so bleeding will more. So we are not using that. Malaria will also not inserted due to increased vaginal bleeding. Norethistron and dipole injection can be inserted, but it can cause irregular bleeding. So answer here will be progesterone. Progesterone, LNG, IUCD is inserted. Next question: which side of implantation will cause severe vaginal bleeding? So here the vaginal bleeding is given. So ovary, tubal, or abdominal implantation will not cause the vaginal bleeding. It will cause the abdominal hemoperitoneum. So the answer here will be internal loss. Maternity doctor was done at 12 to 14 weeks of detects. For IUGR we are doing the umbilical artery doctor. So placenta accreta we are not doing that for 12 to 40 weeks. So for early onset preeclampsia we are going to do 12 to 14 weeks. Okay, answer here will be this. Property contraindicated in rupture condom during intercourse. So it is emergency contraception, so it is inserted in that. For menstruation we are also giving that. For post-molar irritation after topoplastic release will be the answer. Immediate delivery we are also giving it. So next question: 22-year-old female present with the infertility, HSC, hysterosalpingosis, diagnosis is here the angle is lesser 4 degrees, so answer here will be septate. Other options are this is if there is wide angle, the uterus are in the north and south pole, so the answer here will be bicoordinate uterus. This is uterine diagonal piece in which the vagina and cervix is seen separately. So answer here will be the septate uterus. Another question: absolute contraindication for the cervical surgery in the patient with cervix 9.8 cm. So the absolute contraindication is intrauterine infection, cervix is greater than 4 cm, bleeding, uterine contraction, or ruptured membrane. So the answer here will be ruptured membrane. Okay. Recommendation after surgery for the vesicovaginal fistula. So it is not given in the Williams, it is not given in the Lata, it is given in the NC by guideline. So it's by NC by guideline the exchange for 6 months and avoid pregnancy for 1 year. So it would be the answer. Next question: another question was there drug used for abortion is a mifepristone and misoprostol. Okay, so these were the kind of question. I hope you like this video and you will get knowledge from this. So share to your friend and subscribe my channel. Thank you very much.